This webcast has been previously recorded. Any questions will not be taken at this time. Thank you and enjoy the Spasticity webcast. Hello, this is Ashley Ringstaff, a volunteer at MS World. Welcome to the All About Spasticity webcast with Dr. Mary Hughes. This webcast is for educational purposes only. Thank you, Medtronic, for providing an educational grant to support this webcast. Any questions submitted at this time will be answered in the order they were received after the presentation. MS World is a Patients Helping Patients organization that provides information and support about living with multiple sclerosis. The comments in this webcast are based on professional advice, published experience, and expert opinion, but do not represent individual therapeutic recommendation or prescription. For specific information and advice, consult your personal physician. Welcome to tonight's All About Spasticity webcast with Dr. Mary Hughes of the Greenville Hospital System. Dr. Mary Hughes will be presenting her spasticity presentation shortly. After the presentation, we will have a time for questions and answers with Dr. Mary Hughes. Thank you for your participation in this informative webcast concerning spasticity. Dr. Mary Hughes is the chair of the Division of Neurology at the Greenville Hospital System. Dr. Hughes serves on the board of directors for the National MS Society and the Greater Carolina Chapter National MS Society Board. Dr. Hughes' clinical interests have centered around quality of life issues related to living with multiple sclerosis. Dr. Hughes has over 10 years' experience in managing spasticity and has been published in this area and given multiple presentations on spasticity and MS. Welcome, Dr. Mary Hughes.
Thank you, Ashley, and I hope everyone on the line is having better weather than Ashley and I were sharing before we started. Barring any weather-related internet problems, hopefully we'll do well tonight because it's storming here, and I think it's also storming where Ashley is in Texas, so it's quite a weather night tonight. It really is a privilege to be able to talk about a topic that, ironically, is so important, but in so many ways so under-recognized. Before we can even really talk about spasticity, we really need to start with the conversation, what is it? And one of the challenges with what spasticity is that people experience it in many different ways. So for some people, they'll describe it as feeling as they're stiff, the need to constantly stretch, almost more of the Tin Man syndrome. Other people will describe it as a sensation as having their rubber bands wrapped around them or a tightness. There was a journal article many years ago that asked patients living with MS to describe the strangest symptoms they had. And when they did, there were a number of patients who really described having almost like rubber bands or tightness around extremities that really, before really being provoked or being asked about it, people were really reporting. And then my favorite image is on the bottom of the screen. And for some people, spasms. And this is the newest addition to our family here. My son caught the frog, and I thought it wasn't an appropriate image to put in for spasticity, because for some reason, spasticity really correlates with spasms. Many times when people come in and they're talking about their various symptoms, even though they've been seeing multiple physicians, they really have never heard the term spasticity and not aware that that's one of the symptoms that may be attributing. And so one of the goals for tonight is to talk about what is spasticity, to help people assist them in identifying the symptoms, and then talk about the wide range of treatment options that are available for spasticity. And then I think the most interesting part of the conversation is actually to open it up to your questions. So severe spasticity, one of the biggest challenges is it can make movement difficult or uncontrollable. And so spasticity is one of those things that if you ask, what exactly causes it, for those of us who are experienced with MS, we know we spend a lot of time talking about what we don't know and what we don't understand. But we know that it's caused by damage or injury to either the brain or the spinal cord. And that injury the consequence, spasticity, is separate from what may be causing it. So spasticity may happen from stroke or from lack of blood supply to a part of the brain. It can happen because of trauma to a part of the brain or spinal cord. It can also happen as a consequence of demyelination with either the brain or spinal cord. So a wide range of things can cause spasticity. It's a long-term consequence of injury within the central nervous system. And there are many, many disorders that are associated with spasticity as having one of the symptoms. And the most important one that we're going to talk about tonight is multiple sclerosis. So symptoms of MS, when people are describing symptoms, one is increased muscle tone. Now, I've never had a patient come in and say, listen, I have increased muscle tone. But when we're evaluating patients in the office, many times when we go to move or we go to check their range of motion to make sure that the arm will go through all the way full extension, when we're moving it, we may notice that people have a tightness or they feel like we have to overcome that. It's very commonly associated with overactive reflexes, and majority of patients with multiple sclerosis can have overactive reflexes. Involuntary movements or spasms can happen just spontaneously or with triggers. So sometimes if someone has a noxious stimuli, so for example, if they have a bladder infection, they may start having spasms that they didn't have before. One of the challenges with spasticity, it has almost a diurnal variation. And so that means that there are different times of day where the spasticity may be more apparent. So when I'm evaluating somebody in the office at 10 o'clock in the morning, they may not have a lot of symptoms of spasticity. But if I ask the question, how are you doing in the evening or during the night, very often I'll hear that, towards dinner time and the after dinner time, people start having that sensation that they want to stretch. They may notice that their legs are jumping. They may notice that their legs are jumping during the night. Not so much of a problem during the daytime, and so it's certainly one thing that healthcare providers need to be really aware of, to ask that question and ask the appropriate question so we can help identify people who are having challenges with spasticity. The other thing is that spasticity can be present when people are at rest. And so when we have you sitting at the table and we're moving your arms and legs and you're sitting there, you may not see a lot of spasticity right then. But perhaps you walk up and down the hallway, and after you've been walking for several feet or 100 feet or half a mile, you may start developing tightness. So that's what we call a dynamic spasticity. So one of the challenges with spasticity is identifying what are the specific symptoms and raising the awareness that spasticity is a challenge. It can certainly interfere with people's ability to function, and I think even equally important, it may also contribute to people's pain. When we're talking about pain related to MS, there are many things that can contribute to pain, everything from the burning, tingling pain, or what we call more neuropathic pain, to the tightness, the stiffness, the sensation of needing to be stretched. The more we can identify what's contributing to a specific discomfort, the better we can be in overall treating people's comfort overall. How common is spasticity? The irony of it, it's something that many people have never actually really heard the term or not aware that they actually have symptoms of spasticity, but it's a very, very common presentation. And it's estimated that there are more than 500,000 people in the United States. We've talked about the fact that there are many different things that can cause spasticity, everything from cerebral palsy, which is the one that we think about most commonly. It's something that children are born with and have increased tone or spontaneous movements of their extremities, through multiple sclerosis. I always use the analogy of a spinal cord injury when we're talking about spasticity, because there are a few times when you see a new symptom that it may be not necessarily a sign that the MS itself is progressing. And so if we use the example of a spinal cord injury, people who first have a spinal cord injury may not have any spasticity. Some do, but the vast majority of people don't and may not for many years, but later on start developing stiffness or developing spasms. So we know that the spasticity can be a long-term consequence of having an injury. If you look at the example of a stroke, spasticity may not develop for almost a year after the initial stroke. So the fact that we know that it can develop long-term, when we're evaluating people living with MS, the fact that spasticity is a new symptom doesn't necessarily mean that the underlying disease process itself, that multiple sclerosis, is progressing. And that can be very reassuring. Although spasticity in many reports is under-recognized and under-treated, when we specifically ask people of symptoms related to spasticity, people have reported estimates as high as 70 to 84% of people living with spasticity. And probably even more importantly, about a third of people say that their spasticity interferes with daily living. It may make them harder to button their clothes. It may make it harder for them to use their utensils. It may be harder for them to walk or to stay comfortably in a chair because of spontaneous spasms. So it really can have a wide range of impact and very important in identifying and treating appropriately. These are some of the other examples. We talked about cerebral palsy, which is a disorder that you're born with or related related to an injury sustained around the time that you're born. Spinal cord injury is very common. Again, reminding you, it may not happen at the time of the initial injury. And in fact, for many people, spinal cord injury is right at the time of the injury. People are flaccid, have no tone at all, and the spasticity can develop over time. So not all spasticity is bad, and I think that's a very important point to stop and make. We think about spasticity as being a negative symptom, a tightness, a spasm, but there is a certain amount of spasticity that is potentially of benefit. If you're having weakness, your spasticity can at times be used as a tool to overcome or to compensate for the weakness. So if the motor strength is actually weaker, but the spasticity, the increased tone, may help compensate for activity. So for example, if you're having trouble with weakness on one side, the increased tone may help with transfers. And so when I'm counseling folks about spasticity, we may identify that it's there, but we also need to talk about, is it interfering with your ability to function? Is it interfering with your comfort level? Because not all spasticity is bad, and we may be able to use it as a very helpful tool. And so we have to really balance not enough tone, too much tone, and the wide range in between. Can be serious. For some people, spasticity is a very significant issue. There are some people who have limited or spontaneous extensor spasm. If you're trying to walk and then your legs spasms out and you can't bend it when you want to bend it, that certainly can put you at increased risk for falls. Increased energy required to function because you're having to kind of overcome the spasticity. We've done programs in the past when we've tried to demonstrate to families and to children and people living with multiple sclerosis what it's like to experience some of the symptoms related to MS, and I think many of you may have seen some of these. So, for example, what it's like to live with double vision when we can put glasses on and cause people to see double and give a sense of what that's like to live with that. The way we've mimicked spasticity in the past has really been two ways. One is by putting a kind of a rubber band, like those elastic stretching bands, and having people move their arm and then have them move that with an elastic band and feel that increased resistance. The other thing that we've done is actually put a very small amount of weight, like around the ankle, and have people feel what it feels like to have that increased heaviness. And when you're thinking about trying to function, having to overcome that symptom, overcome that spasticity. In very severe cases of spasticity, it can be associated with symptoms, for example, like bed sores. People who are non-ambulatory, who are having spontaneous spasms, the constant rubbing, can cause bed sores and have to be managed from that stem. Relatively rare, but something that's very important, identifying very proactively and intervening with aggressively. Now, we've talked about the spasticity is not all bad, and certainly there's a cycle. So there's increased spasticity that can kind of lead to more problems. If you're having more trouble with reduced mobility, if you're not up and out of the chair and up out of your bed as you used to be, we get increased risk for bed sores, increased risk of infection, and so then it can kind of get into a cycle. And so one of the reasons why it's important to identify spasticity not only for comfort and for a quality of life standpoint, but also to identify it as a long-term symptom that needs to be managed over time. I always like this picture. We've all seen our pets stretch, and certainly, while this is not my dog, this would be an internet picture of a dog. My dog would never stay still long enough for us to photograph him. But can spasticity be treated? And the first line of treatment for spasticity is stretching. Every person living with MS needs to be on some kind of exercise regimen. And certainly at times that may need to be tailored for your specific abilities and for safety. But stretching really needs to be a regimen that is part of that daily routine. And whether that's something you do individually or whether that's something you do in conjunction with one of your caregivers, it needs to be part of that regimen and something that's incorporated. And for those of us who are listening to this webinar and don't have MS, we also know that spasticity and stretching is very important. The increased flexibility decreases our risk for falling as we age. So certainly spasticity and stretching, particularly stretching, is important for all of us. Now this is really a slide that really shows just the wide range of things that are brought into play when we're talking about spasticity management. And there's no one particular approach. I really wanted to emphasize the need for stretching very early on, particularly for people with very mild spasticity. But the other thing is to recognize there are times that mild spasticity can get worse. Doesn't necessarily mean the disease process itself is changing, although that's possible. But when you see prevent nociceptive, that actually says basically anything noxious. So there are times when people have a bladder infection, and maybe they don't have the true sensation of their bladder, but that uncomfortable sensation the body perceives, and they may have worsening spasticity. I've had patients who've had injuries. One of my patients fell and broke her ankle, and after the fracture, obviously there's a lot of pain associated with that, and her spasticity was much worse while she had the pain from the ankle fracture. Once the fracture healed and the pain was better, we were able to go back to our previous management regimen, but during that time we had to increase our intervention. Oral medications, rehabilitation, injection therapy. We're going to talk about intrathecal baclofen, and some of the neurosurgery orthopedic interventions, while are used, are very rarely used, particularly in MS. So oral medications. Well, these are the first line of medications, and many times when I'm talking to people about spasticity, they'll say, "Oh, I tried oral baclofen and I just couldn't take it." And one of the challenges with these medications is that there really is an art to using them. All of these medications potentially have the effect of causing sedation, cognitive dysfunction, and drowsiness. And for those of us familiar with MS, we know that those are some of the very common symptoms that can occur. And so again, it's a balancing act. The appropriate use of oral medications can be very important. One of the caveats is to start low and start very slow. So if I use the example of baclofen, a typical treatment dose where we actually see a benefit may be 10 milligrams, 1 tablet 3 times a day. But when I'm starting it, I start it very slowly. I started a half a tablet at night and let the body adjust to that for about a week. And then go to a half a tablet twice a day and let the body adjust to that for another week. And gradually going up on the medications, a very slow titration, many times can avoid some of the side effects. And so if you've tried the oral medications before and said you just couldn't tolerate it, one of the things to ask is where you started on a low enough dose. While spasticity is very common, many healthcare providers aren't very familiar with how to use these medications, and that's one of the things that I very commonly will come into when people will say, I tried them, I couldn't tolerate them, and we go back and look at the doses and how they were started, and sometimes if we start very low, we can be very effective in managing the medications over time. Unfortunately, there are a significant number of people who, despite having aggressive stretching regimens and despite being on oral medications, may not be able to fully manage their spasticity. Really, the role of rehabilitation cannot be emphasized in living with MS. And the goal of rehabilitation is not only to help maintain your level of function, to help you develop an exercise regimen that you can maintain and continue over time, but also to find ways to compensate for things that you may have more difficulty doing over time. And the rehabilitation team is really key when we're talking about spasticity. We mentioned physical therapy and occupational therapy. There are some people who have more what we call spastic speech, and speech therapy can be very helpful from that standpoint. And I can really tell you the true heroes in caring for people living with MS very often is a rehabilitation team. Injection therapy, if there's a specific muscle group, so for example, if someone has spasms or tightness in a hand or a foot, then a very focused intervention can be very helpful. There are times when people are taking medications by mouth, but will still have a hand that is still spastic, that's not fully responding, and those are times when injection therapy may be very helpful. The goal of that medication is that it's injected at the extremity, and it's designed to block between where the nerve communicates to the muscle. The injections, and the one that we think about most commonly is Botox, very frequently have to be commonly have to repeat it approximately every 3 to 4 months. And so that's one of the challenges, is that they have a short-term benefit. But if we're talking about someone, for example, has a spastic hand, perhaps we've optimally managed the rest of their spasticity by medications. By using injection therapy like Botox, we may be able to help relax the hand, get rehabilitation, occupational therapy, and physical therapy involved, and work on really being able to stretch that. And we may be able to maintain that in a much better way, develop a better functioning hand than we had in the past. We don't use phenol and alcohol as much as we used to. These are been around for a very long time. It's used in the very same way as Botox. One of the challenges that depending on what the muscles are that injected, there's a higher risk for having pain associated to the phenol or alcohol injections. Over time, phenol and alcohol injections are permanent, which is opposed to the Botox, which has to be repeated over time. And I just use kind of just a picture of the tight muscles beforehand. We're used to, dermatology has probably been the most famous with Botox, but certainly we use medications for focal spasticity in people living with MS and other spasticity-causing disorder. This is very rare. It's selective dorsal rhizotomy. It's predominantly used in pediatrics, cerebral palsy. This is very uncommonly done in adults, but certainly there are nerves that sense stimulation, or the sensory nerves are hyperactive. They're recorded from a surgical procedure. The sensory nerves are cut and certainly used predominantly in lower extremity spasticity. And again, can't emphasize again that even though people have had selective dorsal rhizotomy, there's a very intense role for physical therapy afterwards. Orthopedic surgery, again, predominantly used in children. I think one of the things that's been very important is that as we've had other treatment options available, the use of surgical interventions for spasticity has gone way down. Intrathecal therapy is something that's been around for probably about 15 years now, almost 20 years. Certainly one of the challenges is that it's not used probably as much as it is appropriate. When we're talking about using the medications by mouth, where those medications actually have to go to function, to decrease the spasticity, is at spinal cord. Well, if you take a medicine by mouth, it has to go through your mouth, through your stomach, it has to be metabolized by the body, and eventually cross the dural sac, which contains the spinal fluid, and then finally it reaches the spinal cord, where it's able to actually decrease the amount of spasticity. And intrathecal therapy bypasses all of the mouth, GI, stomach, the GI tract, the metabolism of the body, and takes the medicine directly to where it does its good, which is in the fluid circulating around the spinal cord. To give you some idea, when you take the medication by mouth compared to putting it directly into the spinal cord, 1/100th of the dose that you take by mouth actually reaches the spinal cord where it needs to go in order to be able to do its job. And so if we are able to take very small doses and put them in the fluid around the spinal cord, we're able to avoid many of the side effects that people sometimes will experience who are taking medications by mouth. This is the intrathecal baclofen pump, and what you see is the pump on, and it looks almost like a mouse, and then you see the yellow tubing that comes for the mouse. The pump reservoir is implanted in the abdomen. There's tubing that comes from the reservoir and then enters into the dural sac, and then the medication is infused right into the spinal fluid. It's indicated for very severe forms of spasticity. It's indicated for people who are not able to tolerate oral medications when titrated appropriately, and it's indicated for people who, despite being in rehabilitation and exercises, still have not been able to manage their spasticity. Prior to having an intrathecal baclofen pump implanted, one of the things that many physicians will do is actually do what's called an intrathecal baclofen trial, very much like a spinal tap, except instead of taking spinal fluid out, the baclofen, or the intrathecal baclofen, is placed into the spinal fluid, and then it's measured. The benefit is measured over the next few hours. And when you get a bolus like that, it lasts about 4 to 6 hours, and then it wears off. And people can get some sense of what the potential benefit of receiving intrathecal baclofen may be during that time. One of the challenges with intrathecal baclofen is it does require long-term management. The way we communicate with the pump is by using magnets, and it actually looks a lot like a mouse. It's placed over the pump in the abdomen, so you can feel the firmness under the skin. If the scar over the pump is not a giveaway. And there's a magnet that's placed over, and using the handheld device. The amount of medication can be adjusted and managed over time. Now, one of the things about having a pump is it really is a long-term commitment. The reservoir can hold medications anywhere between 3 to 6 months, depending on the dose, so it does have to be refilled. Any medicine that's used for spasticity has to be the patient families need to be very careful about not stopping those medications suddenly because there is a risk for withdrawal. People don't get addicted to their spasticity medicine. It's a tolerance to the body, and you can't stop it suddenly. And so making sure and the commitment that your pump does not go dry, that you're going to follow up with management. But also, the pump doesn't do all its work by itself. And by now you may hear my theme that exercise, 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 particularly in people who have been through oral medications, who go on to get intrathecal baclofen, really understanding that there is a certain point where the spasticity is going to be better managed by the pump. But in order to really be able to regain some of the functional benefits, there's going to need to be a very intensive therapy regimen initiated at that time. What we've really done is kind of in about 30 minutes gone over kind of the wide range of treatment options for spasticity, touched on the manifestations, and that's one of the things, when we talk about MS, we say when you know one person with MS, you know one person with MS, and it's very similar to that when you're talking about spasticity. When you're talking about spasticity, you're talking about an individual's experience with it. Really, it ranges very different, widely from person to person. But I think the key message tonight is to say that to identify a symptom, to give you a tool to go back and talk to your healthcare providers about something that may be contributing to your quality of life, and also be able to have some awareness of some of the treatment options. And with that, I'm going to stop and take some questions. I think, Ashley, there were some questions submitted beforehand.
Yes. Yes, thank you so much for the presentation about spasticity. We really appreciate it, myself included, because I do suffer from spasticity. We do have some questions that were emailed in, and we do have some questions that are being submitted at this time. So I will start with the first question that was submitted by email. If I suffer from severe spasticity due to my MS, should I ask my neurologist for a referral to a spasticity specialist?
So that's a very good question. Of course, the challenge is what's the definition of a spasticity specialist? And I think, certainly one of the challenges with talking about spasticity is that not only is it important to really educate people living with MS, but also to educate the healthcare providers because it really is a symptom that's very often under-recognized. And if your spasticity is a challenge and your healthcare provider is not comfortable with managing it, or you feel that it's not adequately being managed, I certainly am an advocate for a second opinion. I always say, if I take my car into the shop and it continues to squeak, I'll go back several times, or maybe at least one more time. But if it's still squeaking, then I certainly have no problems going for a second opinion. And I think that's a self-efficacy. That's a patient right to do that at any time.
Okay, thank you. And then we have one saying, they have how to tell if spasticity is from mechanical problems or from lesions on spine and or brain, and how does identifying the root cause affect treatment choices?
Okay, so the first thing is to talk about, well, is it mechanical or is it from the brain or the spinal cord? And we know that the actual, where the spasticity or the injury within the body that's causing the spasticity is within the brain or spinal cord. Where we see it is very commonly in the extremity, so in an arm or a leg. And so I'm not 100% sure what's meant by mechanical, but I think that's a manifestation of how we're moving. So although the injury is in the brain, the walking may be impaired, and that would be the mechanical effects of it. Now, there is good news with spasticity, is it doesn't really matter what caused it. And so the way we treat spasticity is the same, whether it's related to a stroke, whether it's related to an injury, or whether it's related to demyelination. And so the real onus is on identifying that spasticity is a challenge, but in the end, the treatment options that we use for that are very similar across all of those disease states.
Okay, thank you. And now we have, how do you identify and manage spasticity triggers?
Okay, so when we're talking about the triggers, we really I'm a big advocate for really looking patient education materials. There's great information, and in fact, I think at the end of this slide there are some, I'll move on to that, some of the resources that talk about spasticity, and I encourage people who are interested in learning more about spasticity to look at these resources. Talking to your physical therapist or occupational therapist about spasticity, and again, going back and talking to your healthcare provider can be very important. And so the more awareness that we have of spasticity, the more aggressive in intervening. And, I always kind of point out it's a two-way street. So while we as healthcare providers very often can recommend therapy, we can recommend exercises, and we can recommend medications, it really takes the cooperation and working with the team to really be the most benefit.
Okay, thank you. Now it says, why and how do changes in temperature, UTIs, constipation, apnea, stress, even too much of a good thing, cause or aggravate spasticity?
So you would think it would just be the bad things that would cause worsening spasticity. And I think that's one of the challenges with MS is that we know that it's very individual from person to person. And so why pain would trigger, or noxious stimuli would trigger spasticity, we're not 100% sure. The one simple explanation, and just because it's simple doesn't mean that's actually the accurate explanation, is that when you feel pain, there are increased amount of transmitter, there's increased electrical stimulations going back to the brain to say this hurts. And that hyperexcitability of the nerves may be what worsens the spasticity. On the other side, for many people, heat is something that will help relax the muscles and decrease the spasticity. So it's very individual from person to person, but it's one of those triggers that we know to watch for. So if someone's spasticity has been stable and suddenly it changed, then we start looking for something may have triggered it, whether that's an infection, whether that's something that's painful stimuli. The temperature we don't have a lot of control over, but being aware of your response to various temperature changes can be very important in helping us manage it over time.
Okay, and then we have one saying how to prepare for flare-ups with spasticity, like post-surgery or long, bumpy car rides.
Mm-hmm. And so that's an excellent question. And so if I'm aware of a patient that has spasticity and is going to go for surgery, then that's a time to have your healthcare providers talk about it. Because certainly if neurologists aren't as aware about spasticity as they should and could be, then other healthcare providers may have even decreased awareness. And so having a plan in place, which includes the person who's going for surgery, to talk about potentially needing to increase the medications in the postoperative phase, and also being aware of the fact that as the pain decreases and the pain is managed well, that you may not need as much as your spasticity. Spasticity is one of those things that really fluctuates. You may have a very constant regimen, but you pointed out the bumpy car ride, which is an excellent example. And knowing in advance that if you have worsening spasticity before you get in a car before a long ride, occasionally what we'll do is we'll use just PRN doses. So before you get in the car ride and you're not driving, being a very important point to make, taking an additional dose of the whatever medicine you're using for your spasticity can be very helpful. So for example, even in times when people have, say, an intrathecal baclofen pump and they don't really require any medications by mouth, there may be times that there are certain triggers, like a car ride, then they may need to take medications in conjunction with that.
Okay, and then we have one, I know you were speaking a lot about exercise and physical therapy, and this one is kind of pertaining to this. I didn't know if you wanted to go any further on it. It says, my right hand is bent at the elbow and my hand cannot grasp. Mm-hmm. Will exercise loosen the muscles? Should I be hopeful of regaining use of my right arm and hand?
Well, I think that's a very important question. So we can treat spasticity, and we've certainly talked about a wide range of options. So if we go to one extreme, we can say from surgical intervention, we can certainly fix the spasticity. The challenge with that is that how much strength do you have? And so when I use the analogy that we used earlier with talking about for programs, for example, that give our families a sense of what it's like to live with spasticity, we talked about having that rubber band on or the additional weight. We can take the rubber band away. We can take the additional weight away by improving the spasticity, but it doesn't change the underlying strength that extremity may have. So if your hand is weak, perhaps by removing the spasticity, you may be better able to exercise. And so for many people, we do see increased function. But when we're making decisions about treating spasticity, we have to be really clear on what our goals are. And so that is something that, there are no promises. If you have good strength to start out with, and you have a significant amount of spasticity, uncovering the spasticity may help you work on your strength. You're still going to have to do the physical therapy. You're still going to have to do the exercises to build up your strength. But I would be very cautious about saying that you'll go back to being full strength. So it's very individual. The other thing is really when you talk about it being bent at the wrist or bent at the elbow, one of the things that we really want to be very proactive about is identifying spasticity very early. So severe spasticity has been there for a long period of time. People can develop what we call contractures. So the tendons actually tighten. So it's no longer just spasticity, it's that the tendons have essentially frozen into place. And the only way to really release those contractures are by surgical intervention. And so for each individual situation, there may be many things contributing to it, but certainly there's a lot of hope in talking about how is spasticity interfering with your ability to function. If we were able to release this hand, how would you be able to use this hopefully more effectively in the future?
Oh, that's interesting. I've never heard that it could actually do that. We have one that it's kind of an explanation and then some questions to follow to figure out some things. It says, I have an aching pain in the bone behind my left ear. It hurts so bad I must press on it, and then the pain seems to go down my left arm, ending with my left hand, making a fist. Is this a spasm? It's especially bad when I drive or any movement like walking. I use a walker. It also bothers me when I'm on the computer.
Mm-hmm. So, I always think back to, my sister is 12 years younger than I, and I was in medical school, and she called me one day and said, I had this pain, it started here, and it shot through. What was it? I said, I don't know. And she said, you call yourself a doctor. And you certainly, nothing more humbling than being a neurologist. We spend a good amount of our time saying we don't know. But one thought that comes to mind as a possible explanation for the discomfort that you're having is something called occipital neuralgia. There's a nerve that comes out the base of the skull and gives a sensation over our scalps. And when you touch your hair, the reason you know that you feel it is because that occipital nerve picks up that sensation. And there are times when that nerve can get irritated, and people can be very sensitive. And so that may be what the pain is that's contributing. Certainly the way to evaluate that is to mention that to your healthcare provider. Putting pressure on the occipital nerve will many times reproduce the pain. And that's something that there are specific interventions, everything from non-steroidals to doing specific nerve blocks of that. But one of the things certainly is that when someone has, again, that's a great example of a painful stimuli that can spread to cause worsening spasticity. So, for example, somebody has a bladder infection, the infection is in the bladder, but their legs are spasming. So it can be a cause of it, but not necessarily a direct link between the two.
Okay. We have one. It says, there was a recent study on marijuana and MS symptoms such as spasticity. What is your opinion on this?
Okay, so there have been many, many studies on marijuana and spasticity. And in fact, when you survey people who are living with multiple sclerosis, there is a significant number of people, some estimates are as high as 1 in 5, and maybe much higher than that, of people who have tried marijuana for MS. And for a wide range of symptoms, including spasticity. When I look at those studies, and when you evaluate people objectively, so for example, when a healthcare provider evaluates the person pre and post marijuana, however that's ingested, the spasticity is not any different. Now, the patient may say the spasticity is not bothering them as much as it did before. They are more comfortable than they are before. And we could argue that that's a therapeutic benefit. When I'm talking to my patients in the office, I just have to remind them that it's not legal in the vast majority of the states. But certainly there is some literature suggests that it may be a symptomatic management. When I'm talking about marijuana in the office, one of the things that I really want to go back and address is what are the other treatments that may be more directed and potentially even more beneficial in treating the underlying symptom like spasticity. One of the concerns about marijuana is because it too does have side effects. And so 70% of people with MS will have issues with cognition. Sustained marijuana use can certainly cause problems with cognition. And so we just have to be aware that although I guess some people would argue it's a natural remedy, it also has potential side effects.
Okay, and now we have some questions that have been submitted during the webcast. Does the D vitamin help the manage of spasticity?
Okay, so I'm not, vitamin D is in dog or vitamin B is in bee? I'm sorry, Ashley.
Vitamin D is in dog.
Vitamin D is in dog. Okay, so so I guess I could have answered it either way, because certainly there's a lot of literature on vitamin B and vitamin D in MS. You know, vitamin D is very interesting. In the last few years, we've had a lot of excitement, and we hear a lot of research coming out about the benefits of vitamin D and MS. We know that potentially vitamin D deficiency may be a risk factor for the development of MS. Unfortunately, that's something that we are very commonly not aware of, and maybe something that we screen in the future and may help prevent developing MS. But the other side of the coin is what we don't know is if we give people who were vitamin D deficient vitamin D, will that actually treat the multiple sclerosis? Does that improve the symptoms related to vitamin D? Certainly, outside of the field of neurology, there's a lot of interest in vitamin D, everything from cardiovascular health. We know that vitamin D is important for the immune system. And so while I can't speak to a direct benefit for vitamin D and spasticity, there is a growing amount of literature that suggests that people who are vitamin D deficient potentially can see benefit from having a supplement because of so many parts of the body that vitamin D is important for its normal health.
Okay, and we have, if one decides to discontinue an oral medication, should it be done slowly?
So specifically, if we're talking about the spasticity medicines like baclofen or tizanidine, yes, it should. Very rare occasions we need to stop it suddenly. If someone, for example, is very sick and very sleepy, we may have to stop it. But patients can go through withdrawal from these medications. Certainly, any stopping of these medications needs to be done in conjunction with the healthcare provider and very gradually in the best case scenarios. So just to give you some ideas, some of the signs of baclofen withdrawal or spasticity medicine withdrawal is increased stiffness. One of the things we watch for example, if somebody has a pump and we're concerned that maybe it's not working well, is if the spasticity gets worse. If people aren't taking people are taking multiple medications, sometimes one pill will get left out of the box and we see worsening spasticity. And so increased tone is one issue, but in the full-blown withdrawal, it can go on to have seizures and altered mental stats. So we need to be very careful about stopping the spasticity medicines fast or quickly.
Oh, okay. Thank you for that one. Are there promising intervention agents in the pipeline? What are they?
For spasticity? So I think, there's certainly, if we're talking about the field of MS and the field of immune modulating therapies, there are a number of medications that are in the pipeline, and that's a whole webinar or 2 or 3 or 4 in and of itself, and that's an area of enormous excitement. And when we're talking about how will that impact spasticity, if we can decrease the amount of damage that's being done to the brain and the spinal cord, we can decrease the likelihood of developing spasticity long term. As far as specific drugs that are being looked at to treat spasticity in new, innovative ways, I think there's not as much research or not as much in the near peer pipeline that's going to be coming available to us. But certainly, when we look at the advances that are being made in treating the disease process more aggressively, then I would anticipate that we'd see less spasticity being experienced for people over time.
Okay. Is spasticity what makes my legs heavy?
And so the term of heaviness, and we've talked about how people will experience it in different ways. And heaviness certainly is a term that some people will use to describe what it feels like to have spasticity or increased tone. But I've also seen patients use the term heavy when they're describing weakness. And so the term heavy in and of itself really has to be correlated with what's seen on the physical exam. So are the reflexes brisk? Is the tone when it's moved up, the extremities move through the range of motion increased? What time of the day are we talking about? That the heaviness becomes more apparent. And so one of the challenges with describing spasticity is many different terms are used, but that's something that has to really be evaluated in the setting of what your physical exam looks like.
Okay. Are there predictors of spasticity and its course?
So, the predictors of spasticity, unfortunately, no. And, we go and even look in other disease states like stroke. It's not 100% of people who have had a stroke that will have spasticity, and we don't have a good way of predicting who's going to develop spasticity more in the future. And that unpredictability is also seen in multiple sclerosis. I think the other thing to point out with spasticity is we really can't predict the course. People will have spasticity develop as a more significant symptom and then plateau or even see some improvement of their symptoms, not unlike many other symptoms that can kind of fluctuate with MS.
Okay. What exercises with what frequency and amount of time/session is usually recommended?
So exercise regimens really need to be tailored to individuals. And I always kind of say the most important exercise regimen is something that you enjoy doing and that you're going to continue to do. No reason to tell you to go running if you don't like to go running. And it really depends on your physical abilities. And so whether that's a regimen that is done in the water, whether that's a regimen that's done more in the form of a yoga or Pilates, or whether that's the more traditional stretching with the stretching bands, I think one of the roles that physical therapy and occupational therapy can play is in helping to develop the exercise regimen. So when we go to see therapists, we go because our arm is weak or because we're having spasticity, but we also go, and here's what we want to have when we leave here. We want an exercise regimen that we can maintain and develop over time. And we have to remember that when we finish therapy, that we continue to do our exercises. I've seen more dusty exercise regimens, which generally do include some stretching over time.
Okay, and we have, how long does a Botox dosage last?
So we use as an average Botox lasts about 3 months. I think when you're first starting with Botox therapy, it really has to be tailored. Again, talking about what the predicting the response of treatment to various injection doses. Like any other medication, you generally start on the lower side and work it up as needed to treat the underlying symptom. Over time, the nerve and muscle communication is not as efficient as it has been in the past, probably as a consequence of the fact that it's been blocked so many times. And so over time, there may be an increased amount of time required between the injections. On the other side is that, unfortunately, particularly for Botox therapy or botulinum therapy, the body can form antibodies to the medication. So the longer someone who's using the injection therapy, the more likely the body is to form these antibodies that may decrease the effectiveness over time. So, again, a very challenging intervention, which is not a surprise when we're talking about a challenging disease state like multiple sclerosis.
Okay, I have MS and usually have spasms in my weak leg in the morning after sleep. It comes with some pain, but it usually is short-lived. What are your thoughts on this?
So the questions that I would ask you to really kind of help tailor the therapy directly to you is what you mean by first thing in the morning. So if it's 2 a.m. and it's waking you up from sleep, even if it's in your weaker leg, we may need to intervene with that. We certainly don't want you trying to go to the bathroom in the middle of the night and having spontaneous spasms in your leg. Never mind the fact that if your leg is jumping while you're trying to sleep, you're not going to rest well. And with fatigue being such a significant issue with MS, it's very important to go back and take a good sleep history and find out if there's anything that's contributing to fatigue, like I'm not sleeping well because my legs are jumping during the night. The other side of that is there are times that we can use some of the spasticity medicines at bedtime that have a long enough half-life that for many people will help kind of alleviate the spasms early in the morning. Certainly stretching prior to going to bed and prior to getting up in the morning can be very helpful. And it may be in certain situations that the first medication that really needs to be taken when you wake up is one of your spasticity medicines. So again, it really depends on the time. It depends on how is it impacting you. It depends on, is it managed with stretching, or do we need to go on to some of the more aggressive regimens? I don't know that I've, thinking back to the question that was asked earlier, how often you should be exercising. The general health rules you see the recommendations like I do on the various TV shows. They've ranged from 3 days out of a week to 5 days out of a week. I think in someone who's experiencing spasticity, certainly having a 10 to 15-minute regimen on a daily basis becomes very, very important. And particularly in people who have more severe spasticity, that may need to be done several times a day. And so really we need to tailor that to our individual abilities and our needs, but certainly exercising 3 to 4 days a week is a general wellness recommendation, regardless of whether or not we're living with multiple sclerosis.
Okay, and then we have, is it common for Botox injections in legs for spasticity to hurt really bad?
So Botox injections are injections. And yes, Botox, the actual injection itself can be uncomfortable. And whenever a physician says uncomfortable, that's a code word for they hurt. But it should be relatively short-lived. And so although the injection itself is not a very comfortable procedure, it really should be, other than some soreness over the next day or so, really a short-lived discomfort. One of the challenges with doing spasticity for the leg is those are very, very strong muscles. They require large doses of Botox and multiple injection sites. And so that unfortunately is one of the reasons that botulinum in the lower extremities, if you're talking about your thighs and your hips, may not be as effective as we're talking about, for example, in a hand or in a foot.
Okay, would electrical stimulation help reduce spasticity?
So theoretically, electrical stimulation would be a noxious stimuli that could potentially make the spasticity worse. There are some various electrical stimulation devices that have been used for foot drop, TENS units, and it's there are transcutaneous electrical stimulation that's been used for pain management. I think it's very individual. If we're specifically talking about a TENS unit, if you decrease the amount of pain that you're having, you may have less spasticity. For some people who have tried to use those stimulation for the foot drop, they may find that their spasticity is actually exacerbated by the little shocks of electricity. So again, it varies from person to person what their responses are, and just needs to be evaluated and be aware of the potential prior to or during trials with either one of them.
Okay, we have time for a few more. Is spasticity more common in some forms of MS than others?
So is spasticity more common with one form of MS or another? Not that I'm aware of. Certainly spasticity, I'm really not familiar with it being more common for relapsing remitting or secondary progressive or even primary progressive forms of MS. I think it's an equal opportunity symptom and not really related to the underlying disease process, the underlying form of MS or stage of MS that a person is experiencing.
Okay. How does one differentiate neurogenic pain and spasticity?
Okay. So neurogenic pain, classically, when we're talking about it from like a healthcare provider standpoint, we're thinking about the burning pain, the tingling pain, the stabbing pain. That's usually associated with more what we call neuropathic pain. Spasticity is not generally described as a shooting pain or a burning pain. It tends to be, people tend to use the term of tightness, a constricting sensation, a feeling that they need to stretch, can be involuntary spasms. And so it can be very hard to distinguish between the two because one extremity may experience both burning pain and spasticity. And so when we're trying to treat the underlying spasticity, many times it's very important to treat both because obviously the neuropathic pain, the burning pain, can be and is usually uncomfortable. And if we can decrease the amount of discomfort from that particular symptom, we may be able to manage the spasticity in a more appropriate way.
Okay, and that's all the time we have now for questions. Sorry we couldn't get to all of them, so we will just close the webcast here shortly, and the recorded webcast will be announced. So, Dr. Hughes, if you wanted to explain this slide.
Okay, so this is, one of the things I think the better educated you are about your MS and the various symptoms that you're experiencing, the better partner you can be with your healthcare provider. And there's no better example than spasticity. These are some of the resources that are available to learn more about spasticity. They include everything from exercises or suggestions for stretching to helping identify some of the symptoms and being able to talk to your healthcare provider about various interventions that may be appropriate for you if you're developing spasticity. And I want to just take a minute and thank you all for listening. I think this is a very important topic, one that when we're talking about actually being able to see people improvement in their quality of life is very, very important to identify and certainly very rewarding in treatment from both the healthcare provider standpoint and for the person who's living with multiple sclerosis. And thank you for taking your time tonight to listen in.
Yes, thank you for your participation in this educational webcast about MS-related spasticity. A recorded version will be available on MS World's website by June 26th of this year. An announcement will be made in the weekly MS World Express newsletter when the recorded version is available. If you are not subscribed to this newsletter, you can do so by going to msworld.org, or you can email msworldnewsletter@msworld.org. Thank you, Dr. Mary Hughes, and thank you to Medtronic for supporting this educational webcast. If you are interested in finding a spasticity doctor near you, there is a link provided on this slide. Thank you.